Roxana, thank you for that extraordinarily kind, generous, overly generous introduction. Genuine honor to follow Bob Bono, really and truly. I've learned so much from him, and it's a privilege and a pleasure to be back in New York, where I learned a phenomenal amount about valve disease, and anything that I say that's incorrect is absolutely not attributable to the fantastic education that I had here. This talk's short, and that's not before you all jump in and say that's because there are no great advances or updates in surgery. There are, but as you know, surgeons not the greatest conversationalists. So I have no disclosures, and somehow that's jumped to the last slide, which is interesting. Let's try moving it this way. Okay, and the only potential conflict is the leadership role I have in primary that Roxana mentioned. New York was a wonderful place to work and study for about 12, 13 years. And I spend a lot of time explaining to people that there is no relationship between Cedars-Sinai and Mount Sinai other than name and perhaps a sort of broad philosophy of clinical excellence and innovation. And although part of that picture is what attracted me, what made me go from East to West Coast, and when I explain to residents that we're recruiting, I say, you know, if I'm trying to describe Cedars, I say it's got that whole East Coast academic powerhouse vibe, but with that West Coast sort of civility. These are the things that really compelled me to say yes, actually, when they call me up. And the first thing is it's just got this amazing clinical excellence in cardiac. You know that probably over the last decade we've performed more heart transplants than any other center worldwide and more ventricular assist devices. You also all know Raj Makar, who we are really proud in surgery to support, just the phenomenal structural heart program he built with Cybel, who's here today also. Between them, they performed on average, I think, 600-700 TAVRs a year, a couple of hundred MitraClips, a couple of hundred or so tricuspids. And it's not about being the Walmart of transplant or the Walmart of structural heart. It's about doing it with excellence and innovating, really kind of pushing the boundaries. And as a surgeon, that is a wonderful environment to join because it means you've got a platform to do all the great things elsewhere. And I was very lucky to walk into a program that actually had been built by a phenomenal group of surgeons ahead of me in the robotic space, and that's been a passion of mine for a long time. I love P2, it's probably my favorite place in the heart. I'm going to really enjoy the discussion about TEER and how we design trials to compare these two fantastic modalities. And it was a huge frustration to me for many years doing everything through a stenotomy. And I think that's one of the biggest advances we can offer our patients. It's something that's been forced a little bit onto us by transcatheter modalities. It's how can we do a better job surgically of reducing the invasiveness of what we do. I won't talk about lung transplant, but oh boy, there's some exciting things coming out of Cedars in that space. Also robotic. Would you believe it? We can do robotic lung transplants. So what I thought I'd do is take a 30,000-foot view. Because if we don't understand this, we are much less able to articulate, advocate for our patients and for ourselves. And these are really important things to understand. This is what your dean is thinking about. This is what the CEOs of your hospitals are thinking about. And frankly, if you've got anybody who runs a budget in a practice, this is what they need to be thinking about. There are some major headwinds hitting healthcare right now. Forget COVID. COVID hid a lot of this. We got billions of dollars from the government to support us through COVID, which have gone away. And now we're sort of seeing a very cold reality. You've got global challenges in terms of geopolitics, wars, unrest, climate, I don't care if you call it climate change or climate events, that have disrupted supply chain and combined with technological disruption has created huge challenges. This is kind of snowballed together with an economic challenge in terms of inflation, recession, and interest rates. Huge changes in us, both as consumers, as patients we shop around, and in terms of staff. We want to work how we want, where we want, and we want better. Employment is actually pretty high. It makes it very difficult to recruit. And then there are huge changes on the medical landscape. Payer reimbursement is not keeping up with inflation, and in the case of CMS, it's being cut. There are gross disparities in healthcare, which we are only beginning to appreciate, and we're being forced to address in a way that's often not financially sustainable. And then technology, it is hugely expensive, but it's what our patients need, and it's driving a lot of change in healthcare. And that has impacted us hugely. It has increased the cost per patient to deliver the same care by about 20% in the last 24 months. Hospitals are therefore spending more to achieve the same, but they're actually getting lower revenue for it. Part of the reason that they're spending more is huge increases in staff costs and patients that will basically be far more mobile. And then as care costs go up and reimbursements go down, that means that when you look at, say, 5 or 6 of the biggest healthcare systems in the US, even though their revenue grew, so they did more, in Q1, they lost between $100 million and $500 million of this year. About 50% of hospitals in the United States are slated to lose money this year, and there's a substantial proportion that are financially likely to be insolvent by the end of this financial year. And before you think, well, hey, isn't that great for me? Because that means, I will be getting more patients at my sort of financially fairly solvent place. That isn't how this works. Many of these patients come from an awful payer mix. It will be challenging for your institutions to manage them. Capacity, certainly for us, is a huge issue. We are 110% occupied most of the time. It means I may struggle to get my cardiac surgeries done. This is a huge challenge for us, and there's not a great light at the end of the tunnel. Some institutions, and this is just pulled off Becca, so I can't speak for this, plan to address this by reducing costs, and because staffing is such a huge cost, they're cutting workforce. And I feel very privileged to work at an institution that is financially extremely thoughtful, and strategically they see their way out of this challenging situation just as clinical growth. It's just grow the health system, grow the volume, grow the reputation, and specifically focus in certain areas, focus on what brings in a contribution margin that's robust. And what's robust? It's cardiac surgery. So we're in great shape. We really depend on cardiology, so the whole of cardiac is in solid shape, and most of the hospitals in that bucket are really trying to grow their cardiac service lines because of this. So you're in a sort of very, very important position here. So let's sort of move away from the financials for a moment and have a look at some of the clinicals, and I'll focus on 3 things in cardiac surgery. Now, first of all, if you take one thing away from today, I want you to remember the next 3 slides. We as surgeons didn't know this, so if we didn't know this, I don't know how we could expect you to know this. This is the results of isolated mitral valve repair in the United States. So this is about 60,000 patients over about the last 4 years. And this is their expected to observed operative mortality. And you can see that for 2/3 of patients, unselected, undergoing isolated mitral repair in the States, the expected operative mortality is less than 1%. The median age of those patients is 65. Overall, if you have a mitral valve repair in the States today, your operative mortality is 0.3%. You cannot even get an appendix taken out for that. And I promise you, that's lower than the 30-day mortality for a MitraClip. And we can get into risk adjustment, but that 0.3% is extraordinary. That's an extraordinary achievement. Since half of patients are under 65, if you look at their operative mortality, look at that. 2/3 of patients are operated on with an operative mortality of less than 0.5% under the age of 65. Most hospitals in the US have not had a mortality in about the last 5 years doing isolated mitral valve repair. That's extraordinary. Patients aged 65 to 74, so that's about another 40% of patients. Look at that mortality. Again, 1/3 of those patients, about 0.5% mortality. And then only when you get above 75 years of age does your mortality start to bump up. And still 1/3 of those patients are coming in with an operative mortality of less than 1%. And on that TAVR slide, low risk was defined as an STS score, i.e. predicted risk of mortality of 3%. I haven't even mentioned 2%. About 10% of patients over the age of 75 have got a mortality in that. So this is extraordinary. It's a real accomplishment. And although this is not an amazing discovery surgically, and it's not a sudden technological leap. That's incremental evolution, advances over sort of the decade have really achieved something, I think, that's completely remarkable, and that's your benchmark, okay? That's the benchmark. Now, that was repairs. We all know that the chance of a patient with degenerative, straightforward P2 prolapse going into the OR and coming out with a repair is incredibly variable. This is New York hospitals, just stratified by repair rates for degenerative disease, and that was a relatively recent cohort that we published in JACC 6 years ago. And that variability is driven by individual surgeons, shown here as red dots. And again, you can see, although there's a bit of a volume relationship, there are some low volume surgeons with outstanding repair rates, and there's a high volume surgeon who's got a repair rate of about 70% for degenerative disease, which is poor. I mean, that's kind of embarrassing. You know that we want to send our patients to surgeons that will send the patient out of the OR, not just with a 0.3% mortality, but with a 95, 99% chance of having a wonderful repair. And there's a difference in durability by surgical expertise. Here, I've just stratified surgeons by whether they saw the valve more than twice a month or less than twice a month. And you can see that the failure rate within 12 months, which we can all agree is usually technical, it's unlikely to be endocarditis, it's probably not disease progression, it's a technical error, was double with surgeons that saw the valve less frequently than twice a month. So how do you find a good quality program? So here's the second advance. The first advance is amazing results in terms of low mortality. Here's the second advance. You can now all find great programs. STS public reporting was a good start, tells you about mortality and stroke. It does not tell you about repair rates for degenerative disease. I mean, to me, that's a little shocking, but it doesn't. And there's no plans to. Whereas this does. So this is the American Heart Association mitral valve repair reference centers. There are only 22 currently designated in the US. You have to send 3 years of your patient outcomes, all of your consecutive degenerative patients. You have to demonstrate, you have to send the echoes. They are adjudicated by a committee. And if they approve your results, and it has to be about a 95% repair rate consistently over a certain volume threshold, you get this. And huge credit has to go to Mount Sinai, and specifically David Adams, for pushing this. Because for years, cardiologists have asked, well, how do we know? And patients ask, how can we find out? Well, now you can. So that's the second advance, more sophisticated public reporting. And the third thing really is TIA. And I'm going to claim it as a surgical advance, because obviously it was the surgical technique, Ottavio Alfieri, that came up with edge-to-edge suture. And obviously one of the clinicians on the patent is Mehmet Oz. And we can argue about whether we would call him a surgeon, but let's give him a hall pass. He's a surgeon. And again, this is kind of extraordinary. This is all etiology of mitral disease in the US, CMS data. So this is patients over the age of 65. And you can see this extraordinary uptake in TIA that's overtaken surgical repair. This was published in JAMA Cardiology earlier this year. So you might be reassuring yourselves, well, that's functional, it's not really degenerative. Well, here's degenerative patients identified through CMS. So I can assure you that even though I've done the vertical axis as a percentage, that when you do it as numbers, MitraClip has in no way expanded the total population of patients having mitral intervention. That increase in MitraClip is exactly as you see it there. It is at the expense of patients that were previously undergoing surgery, and that's a large proportion. So mitral valve repair is down by over a third, and as MitraClip has increased to 23-fold. So we are doing clips in patients that were previously surgical candidates, and you've just seen a graph that shows what surgical candidates can expect in terms of mortality. They are predominantly less than 1% risk patients. There are very few patients that are more than an STS risk of 2%. This is propensity match data, and this for me is the rationale for doing a trial, because even with propensity matching, you cannot adjust for the treatment allocation bias that's absolutely inherent in this patient population. You can show fancy survival curves that look impressive, but there's a huge selection bias there. So that's a rationale for a trial. And this is just the clinical rationale for looking at it. These are patients that were all given MitraClips as their first approach, and they're all prolapse patients. And it just gives you an idea of quite how challenging it is to repair these valves if they've failed after a tear. The tear essentially it's designed to sclerose to both the leaflet edges. It really messes up the captation zone. You're often having to chop out half the subvalvular apparatus. We've, in our series at Cedars, probably repaired 60% of these. Nationally, it's a 5% repair rate. If you're going to the OR because of a failed mitral clip, if it's late, early it's a little easier, you can take them out, but it's 95% of those patients are getting replacements. And I think that the primary difference, and again, we're going to talk about this at length, I hope, is that surgery is a strategy for every single morphology of mitral valve disease. There's not one degenerative valve that isn't a joy to repair and that you shouldn't be able to leave the OR with 0 or trace, or at worst, absolute worst, mild MR, and no gradient to speak of. And the durability, after you've also treated hopefully AF and stroke if you need to, is outstanding. This happens to be our robotic series of, I think it's 1,000+ patients, and these are very similar from expert centers. You go out to 10 years, 15 years, it's about 10% of patients will have maybe 2+ MR. And I think the third advance that then I will really sort of emphasize for me is TIA has really forced me, and the opportunity to go to LA has really kind of accelerated that, to just deliver something that is so much less invasive. I was impressed by the 55-minute procedure. Skin to skin, robotic mitral repair at my shop is 2 hours. Wheels in, wheels out, it's 3 hours. If I want to follow a case, I'm following a robotic case. It's efficient. It's good for the patients. The results are just beautiful. It's a joy. It's an absolute joy. It's really transformative. And it's sort of really what patients want when they understand the trade-offs, because ultimately it's not just about that incision. It's really about that. It's that normalizing life expectancy and quality of life. So implications, I think are very much this. If patients can Google that, then they're going to do this. This is where we get our patients from, or where I get my patients from, all over. And the economic drivers that I started off with are really going to accelerate it. And that shift in what patients want and what they expect is really going to accelerate that. So I think that's my last take home. Thank you very much. I've given you 2 minutes. I will stop there, and I'm happy to take questions at the end.